This program is brought to you by Emory University.
Hi, good morning, everyone. Welcome to another exciting Grand Rounds. It's my pleasure to introduce a friend and a colleague, one of our own, Dr. Rebecca Leleiko. Dr. Leleiko graduated from NYU Medical School and then completed her residency at Emory, then did her cardiology fellowship and vascular medicine fellowships at Boston University. She worked at the Boston VA for a while and then decided to come back to Atlanta, and we were very glad that she did. She is a co-program director of Emory Vascular Medicine Fellowship and practices general cardiology and vascular medicine with an interest in congenital and acquired aortopathies. Today, she's going to talk to us about aortic aneurysm, where we came from and where we're going. And thank you for volunteering to give this talk.
Thank you, Pooja, for that kind introduction. My goal is to keep everyone awake after Super Bowl Sunday, so we'll see if I succeed. I have Great, thank you. I have no disclosures. So my learning objectives today are to teach you something that maybe you didn't know about the history of aortic aneurysms. We'll review a few cases and then touch on some of the, I think, highlights of the new guidelines from the ACC-AHA that were published in November 2022. So for starters, what's the important reason why we should care about aortic aneurysm? Aortic aneurysm is the 14th leading cause of death in the US and the 19th leading cause worldwide. Aneurysm is the second most common disease affecting the aorta. There's 15,000 deaths in this country every year associated with this. Worldwide, the impact of aortic aneurysm is large and increasing. This graph is showing it by age. So of course, the oldest members of our society are the most affected. And the US is uniquely high in prevalence compared to the rest of the world, together with some other countries in the East, as you can see here. So for starters, we're going to do a little history lesson just for something a little different. Despite those recent stats, this is not a recent problem. I think most people can identify the person on the right. Can anyone identify the gentleman on the left? Anyone here or online? No. Dr. Clements? No. It's actually King George II, but good guesses. He's actually the namesake of Georgia. He died in his bathroom, collapsed, sudden cardiac death, and had an autopsy that showed thoracic dissection. And Albert Einstein died of a ruptured abdominal aorta, and we will review his case a little bit later. So this is a little bit of a timeline of aortic history, and you can see it starts in almost 2000 BC with a little bit that we will review, and then there's a little pause. But by and large, most of what has happened in the last 100 years or couple hundred years. Don't worry too much about the details here because we're going to review it. It's just sort of to give you an overview of what we're looking at. So 1515 BC is when it's estimated that the Ebers papyrus was written. This is the most extensive and preserved historical document of the ancient Egyptian medicine. And they put a lot of emphasis on the heart, and they had the Book of Hearts. They felt that the heart was the center of everything, and that all bodily fluids passed through the hearts, and that the regulation and passage of everything went through the heart. They also had a comment specifically where they described aortic pathology. And as you can see here, they felt that only magic can cure tumors of the major arteries. So this is sort of the first recorded description of aortic pathology from quite a while ago. It's named after one of the people who bought it and has now been donated to a museum. Fast forward 1,000 years. And Aristotle first described the word aorta in 4th century. Aneurysm is derived from an ancient Greek word that means widening or dilatation. Ectasia also is from a Greek word ektasis, which means stretching or tension. So fast forward, Christ is born, and now we're in AD. I think many may be familiar with Galen. He was considered the physician to the gladiators. So he was sort of like, took care of them after combat. He was considered the first trauma surgeon. He was a Greek physician, and he had a particular interest in anatomy and in dissections, and he performed a lot of specifically dog vivisections. You can see a schematic that's based on his manuscripts that he published about his idea of anatomy. And he described arterial aneurysms as localized pulsatile swellings. One of his contemporaries, Antyllus, was also a Greek surgeon around the same time. And he actually was documented many years later to have operated on peripheral arteries by ligating them distally, proximally and distally, left the aneurysm sac there. And this is Orbazus, who had reported on his techniques 200 years later. So that's why we know about him. And then there's a bit of a gap. One, in the interest of it being an early morning, I did leave out a gentleman by the name of Aetius of Amida, who in the 7th century took to opening aneurysms and packing them with incense, which, because at the time they felt that if you don't have purulent drainage or pus, then nothing heals. So I give you that little tidbit. But I do have some other images. In the 1500s, Andreas Vesalius, who's pictured here, sort of the founder of modern anatomy. And in his books, he described both thoracic and aortic aneurysms. There was a period of time when people were working on some different ideas of ligating vessels. Specifically, Matthias Perman operated on aneurysms in the antecubital space, which was actually quite common because of bloodletting at the time. And that was where they would bloodlet. John Hunter and his brother William Hunter were both physicians interested in arterial system and aorta. John Hunter documented ligating of popliteal artery, and his protege, one of his students, was Astley Cooper, who is well known for the first attempt to ligate the abdominal aorta. So they had a young man, I think about 38 years old, who had a ruptured iliac aneurysm, and they ligated his aorta just above the iliac artery. He died 48 hours later. But this was famous enough to put that specimen into the Museum of Pathology in London, if anyone wants to go see. Some other methods, as we move into the 1800s, this is actually the first time that anyone described or tried endovascular or endoluminal anything. So at this time, Charles Moore developed a wiring technique whereby he put many, many yards or feet of wires into an aneurysm sac to induce thrombosis. And at the top here, you can see a spool of wire, and you can't really appreciate it, but B there is like a Emory paper or like sandpaper, essentially, that they would use to rough up the wire to give it more surface area in order to induce more thrombus. So they have there's one report of them introducing 26 yards of wire into a thoracic aortic aneurysm. Patient expired, but the aneurysm had thrombosed. And as you can imagine, there were complications such as distal embolism and sepsis. But this was used at the time with varying success. On the right here, actually really interesting, this is called Colt's apparatus. This is very forward for the time, essentially was compressed when it was introduced, and then it opened to a 3D sort of pile of wires, as you can see here. So sort of, the beginnings of some of the stuff to come. In 1879, Alfonso Corradi decided to connect the wires to a battery to give some electricity in order to further the thrombosis. So for a time, the Moore-Corrodi technique for electrothrombosis was used. In the late 1800s, Rudolf Mattes, who's sort of considered the father of vascular surgery, introduced aneurysmorphy, which is very hard to say. And this essentially was a surgical technique that was used for many years, whereby they essentially open the aneurysm sac and then collapse it on itself and then sew it back so that the lumen is the appropriate size. And there's a history of those who attempted this. The first successful procedure was in 1939, so it took a little while, attempted by many people. And you can see here, this is the first publication describing the technique in 1903. So most of what I've been describing was used on abdominal aortic aneurysms. In general, the thoracic aortic aneurysms were considered to be inoperable. And the only real procedure that I was describing was the wires that were used for that. So, only the endovascular, endoluminal things. But as we move into the mid 1900s, folks were looking at how to repair some of these. And of course, the best patients to start with were those with aortic coarctation who had developed a really robust collateral system. So in 1941, John Alexander and Francis Byron reported on this resection. It was a pretty young man with a giant thoracic aortic aneurysm associated with coarctation, and they resected the whole thing, ligated it, no anastomosis. This is a picture of the surgical specimen, and you can see here the aneurysm measured 11 by 8 centimeters and took up 7.5 centimeters of the aorta. So this was giant. The patient actually did very well. So this is very exciting. But of course, not everyone, you can just ligate their thoracic aorta, right? So moving around the same time, really, so I think it was in the 1930s that cellophane was developed for various scientific uses. And early on, it was used to band arteries. And in 1943, it was ported on to actually treat subclavian artery aneurysms. And the idea was that the cellophane would induce fibrosis and thus sort of strengthen the artery and reduce the likelihood of rupture. In 1948, C. Rea published on the treatment of abdominal aortic aneurysm with cellophane. And famously, Albert Einstein actually went in for a GI procedure in 1949 with Rudolf Nissen, who's well known. And when he opened him up, he actually found this large AAA, whereupon he wrapped it in cellophane. And Albert Einstein survived for 6 more years with his cellophane wrapped aorta. At that point, he presented with presumed rupture, and they offered him surgery, which was a little bit more advanced at that time, and he declined and died. But he made it 6 years with cellophane. Now, finally, we're moving into a more modern stage. In 1944 in Sweden, doctors Crawford and Nyland performed the first end-to-end anastomosis of an aorta after resection. This is obviously going to be a smaller area of coarct, and they published on this. And shortly after, Robert Gross in Boston followed with the same procedure on this side of the Atlantic Ocean. And a few years later, Dr. Gross, or depending on what you read, Henry Swan reported the first aneurysm resection where they actually replaced the aorta with a homograft. So the homografts had been recently developed in Boston by Dr. Charles Huffnagel, who basically removed, post-mortem, removed arteries, freeze-dried them, sterilized them in the cyclotron at MIT, and then they were ready for implant. So this was a real big step in terms of being able to repair these aneurysms with something resembling, essentially a new blood vessel. So there was a report also of Dr. Schaefer and Hardin, who resected a AAA and replaced the segment. And then Charles Dubost, who performed a successful procedure, replacing that with this interposition graft with end-to-end anastomoses. And in 1966, Dr. Creech described the combination of Dr. Dubost's technique and Dr. Matta's technique of endoaneurysmorrhaphy. So it's sort of a big deal. I know we're not surgeons, but it's still exciting. And of course, DeBakey and Cooley had a whole host of successes. Some of these things were repeated that other people had done, but they also successfully repaired thoracic aneurysm, resected an aneurysm in the distal arch. They were able to replace a thoracic aneurysm with a homograft, and importantly, they did a total excision of the aortic arch and eventual replacement with a homograft on cardiopulmonary bypass, which was very new at the time. And there's some cool pictures of what they did here, really forwarding things. And finally, moving into what we're more familiar with, prosthetic grafts were starting to be used just experimentally in the early 50s. But in 1954, Dr. DeBakey collaborated with this textile engineer to design Dacron grafts. It's really interesting sort of how they went about what was important for these grafts. And by 1958, they had been introduced and pretty quickly and widely adopted. Because of course, homografts were not really a good sustainable method for treatment in terms of being widely available. And then we do have a report of a thoracoabdominal aortic aneurysm repair. So finally, moving into something we're more familiar with, the development of the endovascular techniques more than just the wiring. Dr. Julio Palmaz was responsible for the first balloon expandable vascular stent, which was approved or ready for commercial use in 1986. But before that time, Dr. Perotti, who both of those men were Argentinians, was watching people die after a surgical repair and thinking there had to be a better way. Anyway, I thought this was a neat story. He really had no funding, had no support for what he wanted to do. And he ended up sort of like collecting these street dogs. Probably wouldn't go past the IRB today, but had these street dogs. He replaced their aorta with a graft that had an aneurysm, and then they would use their endovascular experimental graft. And then he put them on his friend's farm and observed them, and they did very well. And as the story goes, in 1990, the president of Argentina called him up and said, "My cousin has a AAA." And it's sort of a funny story because according to what I read, they met with him and he reviewed what they had done. And they said, "Well, you have a lot of experience with this." And he said, "Well, in dogs, not in humans." But at any rate, they went forward and it was successful. And a few years before, this was a Ukrainian doctor, Dr. Volodos, who had performed a thoracic aortic endovascular repair in a human patient. And that was a post-traumatic repair. So all these things kind of on different parts of the world going on. But this sort of ushered in the new world of endovascular repair. And if we fast forward, in the last decade, when it comes to AAA repairs, open procedures have fallen by 80%. And my colleagues estimated that about 80% of our both AAA and thoracic aortic aneurysms here at Emory are performed endovascularly. So quickly, that was a little summary of the last 4,000 years of aortic aneurysms. So I'm going to give, for the second part of the talk, I'll review a couple cases and then review some of the newer guidelines that I think are pertinent to us. All of these patients were mine. So this was a 75-year-old male with a history of coronary disease and an ischemic cardiomyopathy who had a known abdominal aortic aneurysm that was being monitored. These are some ultrasound images. And you can appreciate here that the measurement of the sac was about 5.5 centimeters. This is, of course, a short axis. And here in the transverse, the patient's head on the right side. So that's the proximal aorta. That's relatively normal, and moving into the aneurysm sac with some plaque buildup there. We'll review what happened to these patients at the end. The second patient was an 82-year-old man with an abdominal aortic aneurysm that had actually just been noted incidentally when he underwent a PET scan for follow-up of his prostate cancer. This was a very sizable aneurysm, measuring, I think it looks like about 7.5 centimeters. I mean, you could see a lot of thrombus formation, which is very common. And here again on the left side of the screen, you can see the proximal aorta, SMA, and then his very large aneurysm. This is a CT image of it, where you can also appreciate the calcification in the vessel wall. And the third case was a young man, a 47-year-old with a history of mild hypertension, who had gone to his primary care doctor just complaining of palpitations, and proceeded with an echocardiogram, which showed a fairly sizable aortic root. The patient had no real significant past medical history beyond his mild hypertension, no family history of aortic aneurysm, dissection, or sudden death. He was relatively normal height, normal facial features, nothing very remarkable there. Here's a couple images from his CT scan with measurements just a little bit above 5 centimeters. So we'll come back to those folks. But now we'll do just a little talk about aortic aneurysm. We use the term aneurysm in medicine and cardiology specifically for various things. Technically, the term is that it means 1.5 times the normal size of a vessel. Obviously, we use it to talk about ventricular aneurysm or interatrial septal aneurysm, but the general agreed upon definition is 1.5 times normal size. And this is appropriate when we define aneurysms of the descending thoracic and abdominal aortas. As you can see, the aorta tapers from proximal to distal. The abdominal aorta is the most common site of aortic aneurysms, about 2/3 of them. And a great majority of these fall underneath the renal arteries or infrarenal. And the definition of an abdominal aortic aneurysm is when the aorta is greater than or equal to 3 centimeters. We do call ectasia or mild abnormality at 2.5 to 3 centimeters. So this does fall with the 1.5 times normal. Risk factors for AAA are similar to those as for cardiovascular disease, with smoking also just being a real independent risk factor. The other ones that are common to us being male, being white, hypertension, cholesterol, high cholesterol, age, but also important our family history. Someone who has a diagnosis of atherosclerotic heart disease is going to be at higher risk. And importantly, any inherited vascular connective tissue disease as well. The diagnosis of AAA in recent years is often made via screening. Taking a look, if you're screening high-risk populations, you can come up with a positive rate, almost 8%, certainly not true in all populations. But the U.S. Preventive Task Force has recommended screening 1 time for men who have ever smoked, ages 65 to 75. Screening is generally done via ultrasound because this is highly sensitive and specific and is relatively affordable and doesn't use radiation or contrast. But the newer ACC/AHA guidelines, well, I will say that in general, cardiology and vascular surgery have always recommended a little bit more robust screening than U.S. Preventive Task Force, which tends to be very conservative. And the new ACC/AHA guidelines also recommend screening for men or women who have any first-degree relatives with the AAA. And this is a little schematic. It looks busy, but it's actually quite simple that I appreciate. That helps us decide who should be screened. Right in the middle with the green, you can see men with a smoking history or any family history should be screened. Women with a family history should be screened. Women who have ever smoked, it's certainly reasonable. That's a two-way recommendation. And then for younger patients who have risk factors or a family history, it could be considered with a 2B recommendation. They recommend against screening patients who are older, who have already had a negative screening test and are asymptomatic. And then what do we do once we've diagnosed this common question? And their recommendation is in the smaller diameters, less than 4 centimeters, that you can proceed with imaging only every 3 years. Less than 5 centimeters in men, less than 4.5 centimeters in women. Once a year is reasonable. And as we get into the higher numbers, then you can go to imaging every 6 months. I will say from a clinical standpoint, I think imaging every 3 years is always sort of a tough one because you tend to lose people to follow up. So, personally, I'll probably tend to do more every other year for patients or every year for patients like that, hoping to not lose them forever. But that's a personal thing. And then when do we intervene? So this hasn't changed much. Level of evidence A for men who have 5.5 centimeters and women 5 centimeters, this is an appropriate time to intervene. And level of evidence B, patients with any symptoms that are attributable to AAA. So thoracic aortic aneurysm is different from abdominal aortic aneurysm. While abdominal aortic aneurysms are associated with atherosclerosis and risk factors for atherosclerosis, aortic root and ascending thoracic aortic aneurysms have a strong genetic influences. Approximately 20% of patients have hereditary aspects, have first-degree relatives who are affected, a large amount of them. And the descending thoracic aortic aneurysms are going to be similar to AAAs. And it's felt that this may have to do with the fact that the vascular smooth muscle cells actually originate from different parts in the embryo. The great vessels and the ascending aorta come from the neural crest cells, whereas the descending aorta and abdominal aorta come from the paraxial mesoderm. So the other thing I will say quickly is that although abdominal aortic aneurysms are associated with atherosclerosis, the pathophysiology is different. So this is a medial degeneration of the vessel wall. It's not the same pathophysiology as atherosclerosis. It's just associated with it. So unlike the descending aorta and abdominal aorta, the aortic root and ascending aorta, using the cutoff of 1.5 times normal really doesn't cut it. If you think about taking an average 60-year-old man who has an aorta of 3.5 centimeters, which we wouldn't really blink much at, we would have to wait till his aorta was 5.25 centimeters, 5.25 centimeters before we called it abnormal. And obviously that doesn't fit. So the multi-ethnic study of atherosclerosis took a look at this. So this graph shows basically they compared patients, they used comparison of aorta of 3.4 centimeters or smaller. And they looked at the risk of dissection and population risk as at each diameter. And they found that the risk really starts to go up at 4.0. So the newer guidelines now recommend, just jump forward for a second, calling a aorta dilated when it's 4 centimeters and an aneurysm at 4.5 centimeters. This is assuming the patient is within 1 to 2 standard deviations of the mean for height or body surface area. So we can adjust that accordingly. but this is new. And, of course, the question is what is normal? So just to go back in time a little bit, in 1980, we were using M mode for measurement. And so you could see here, there's a formula that took into account body surface area and age. In the late 80s, Dr. Mary Roman, at this point we had 2D echo and we're able to visualize the ascending aorta. And it was acknowledged that the dilatation of the ascending aorta was really of clinical significance for patients with Marfan's or without Marfan's as well. And so she took a look at this and, confirmed, yes, aortic size depends on age. It depends on body surface area or height and sex to some extent. But actually the M mode measurements were significantly lower by about two millimeters than 2D measurements. So we've obviously shifted to that. And the newer guidelines, along with giving us the recommendations for size, also give some guidance in terms of how to measure. They recommend, for those of you who read echo, measuring leading edge to leading edge, and also give a recommendation for the cross-sectional measurement. And for our radiology colleagues, they also give recommendations not just for measurements, but also for reporting in order to keep things consistent, because of course that's important. Of course, we know that there's caveats to measurements. They are not always the same across modalities, and they can be different depending on how you measure. And of course, they depend on the quality of imaging. So that needs to be taken into account. So unlike with AAAs, thoracic aortic aneurysms are often diagnosed incidentally. So our patients undergo an echo for something else, like my patient in the third case. Very common for people to get a coronary artery calcium score, and their calcium score might be 0, but they have a thoracic aortic aneurysm, or other things like cancer screening or testing. The thoracic aortic aneurysms can sort of briefly be put into a few different categories in terms of management. And I think about this as those with no family history or identified genetic variant are going to be what we consider sporadic. Those with a positive family history, but no identified genetics. And those with a positive family history and identified genetics. And that includes those with syndromic disease and non-syndromic. So the syndromic are the ones that affect more than just the vascular system. And then the non-syndromic really isolated to the blood vessels and the heart. And bicuspid aortic valve is separate. Of course, this is considered congenital, but it's distinct in terms of management. So that's how I look at those. But that also brings up the question of when to consider genetic testing. And this, I think, gets asked a lot. On the left here, I've sort of discussed when I think about it. And then here are the new guidelines that are similar with one addition. I always think about genetic testing in my patients with thoracic aortic aneurysm who are less than 60 years old, who are younger. Anyone who has a family history of aortic aneurysm, aortic dissection, sudden cardiac death where you really don't know what happened, and then anyone who has vessels, other vessels that are affected, so intracranial or peripheral aneurysms, we're going to think about whether they should be tested for something else. And by and large, the recommendations from the new guidelines do, mostly support all that. If someone obviously has features of Marfan's or Loeys-Dietz or vascular Ehlers-Danlos, then they should be tested. People who have a family history or who have other aneurysms should be tested, and then those who are younger. Interestingly, they are recommending that those with sporadic, those who are sporadic and older, greater than 60, they're actually recommending imaging at-risk family members, and that's new. I'm not sure how feasible that is, but it's something that we're going to have to think about. If the family members have any abnormality, then they recommend genetic testing at that point. And if they don't, then you stop. If genetic testing for any of these folks is positive, then they recommend cascade testing, which makes sense for at-risk family members. And if it's negative, they are recommending just screening via imaging. So that's logical. And of course, it's an entire other talk to talk about genetic aortopathies, but just so you have an idea, there's a pretty common panel that's tested by Invitae. It's called the familial TAAD panel. I generally send my patients to genetics because I really appreciate the genetic counseling piece of it. But this is something that can be ordered if you wish. And so basically this tests for the ones that you've heard of, and then a whole lot of genes that you haven't heard of that generally affect the vascular smooth muscle cells, autosomal dominant by and large. So in terms of surveillance, these are the new guidelines. I kept it in here because it's relatively simple. Class of recommendation level 1 is really just in patients who have a dilated aorta. We should be looking at their aortic valve via echo. So that's an important one to remember. And then they give a 2A recommendation in terms of checking a CT scan, make sure that there's no areas of the aorta that we can't image on echo that are dilated. And then in terms of follow-up, and this is, I think appropriately left up to the clinician. Generally, if it's above a certain level, I might do a 6-month follow-up to make sure the rate of change is not too fast. And then based on that, you can think about every 12 months, 6 months if it's pretty big, and get into 24 months if things are pretty stable or not too large. And then when do we intervene? Again, always the question, and an important change in the new guidelines here. So the new guidelines recommend for sporadic and bicuspid aortic valves, still level of class of recommendation 1 to intervene at 5.5 centimeters. Remember, we're talking about the ascending thoracic aorta and aortic root. I'm not really focusing on the descending aorta today. But a new recommendation, which is a 2A recommendation, is to intervene on these patients at 5.0 centimeters. And this is recommended if you are at a high volume center with a multidisciplinary aortic team. Of course, taking into account what the patient wants as well, this is something reasonable. And so this is a change for us. For Marfan syndrome, recommendation is 5.0 centimeters and 4.5 for those at increased risk at a high volume center. So all of these thresholds can be adjusted based on genetics, based on aortic growth rate, and based on indexed aortic dimensions. You can index by body surface area, you can index by height, you can take into account either the diameter or the cross-sectional area. There's a few ways to do that. So what are the features that are associated with increased risk, which is always a question. This is specifically in patients with heritable thoracic aortic aneurysms. So anyone who has a family member who has dissected at a lower dimension. And we always ask patients, if they know, and they usually don't, if they have family members, how big was the aorta when they had their event. And I think we're now moving into a time when we're making, that's been recommended to be documented by surgeons so that we can guide family members. Anyone with family history of a sudden death in a young person, and then rapid aortic growth. And I think this is another important thing that was defined. We've always defined rapid growth at 0.5 centimeters per year. And they've now added the recommendation if the aorta grows 0.3 centimeters per year for 2 years in a row. And that's true whether it's heritable or not. So back to our patients. My first 2 patients very routinely underwent endovascular aortic repair. This is, I believe, the second patient post-op. This is his residual sac here, just as big probably initially, but I think it should be decreasing in size by now. And we could see his graft here. There was no evidence of endoleak or any communication, and he did and is doing well. Patient number 3, interestingly, was referred to genetics because he was so young, where he was found to have an FBN1 mutation and met several criteria for Marfan syndrome. And based on this, was recommended to proceed with surgery. He ended up putting off his surgery because of the pandemic, but is still alive. So in summary, aortic aneurysm is responsible for significant morbidity, mortality, both here and the rest of the world. Treatment has really advanced, and we have a lot of options available to us today. And I think that the updated guidelines will sort of help us to better care for our patients and know how to proceed with monitoring and intervention. So I'd be happy to take any questions at this point. Thanks for trying to stay awake post Super Bowl Sunday.
When it comes to screening, so we know that we should screen men between the age of 65 to 75 who have ever smoked and like before. But when it comes to women, so if a female has a family history of aortic aneurysm, especially ruptured aortic aneurysm, do you recommend they screen whether or not they have ever smoked?
Yeah, so the question was in terms of screening for AAA for women with a family history. And the answer is yes. And actually, I think the newer guidelines support that too. Now, I suppose you're going to have to get insurance to cover that. And that might always be the challenge because the U.S. Preventive Task Force does not. But you can see here, women with a family history of AAA are recommended to be screened in the newer guidelines if they're greater than 65. Now, for younger patients, of course, if someone said, my family member, especially if it was another woman, had an AAA at 50 or at 60, then you're going to want to screen them before 65. And that's where the 2B recommendation comes in.
Any family member, it doesn't have to be.
Oh, it would be first degree. Yeah, first degree. I mean, of course, we all use our judgment and we all get anxious patients and have to decide. An abdominal ultrasound is a relatively benign test. And I've certainly done them on some anxious young people before. But yeah, that would be first degree relatives.
Good, Rebecca. It seems to me that AAAs often surprise us. And they're like, how do you diagnose a AAA? Well, chiropractors diagnose a lot of them. And they x-ray the back. When we see the calcium, they see the calcium, they send them somewhere, or you have a flat plate of the abdomen for one thing or the other, the calcium is seen there. And always, if you're examining a patient in the clinic, the question is, do you check them for AAAs? Then the question is, how do you do it? And when I'm with the fellows and residents, and I do that, they kind of look at me funny. So I first press down deeply down in here. If you got somebody that's got a very protuberant abdomen, it's an issue. If they have a scaphoid abdomen, it's different, and you can kind of get on the sides of it. And many times I've been fooled thinking there was one present, and it was not one present. But anyway, I sent them down for an ultrasound. And so the diagnosis is always amazing to me. Diagnosis of ruptured aneurysm has always been interesting too. One time I sat with a man all night trying to figure out why his heart rate was 110 and his blood pressure was like 100. And finally I looked at his belly and it was pulsating. I said, he's got a ruptured aneurysm. So they're tricky. And all the genetic things that you say and smoking as a risk factor is in the equation. So Dr. Hirsch used to talk about aneurysms that are seen in Africa that are congenital in the aorta. And I think maybe one time we've encountered a patient like that. Did you encounter anything like that?
Isolated abdominal aneurysms?
Yeah. Aneurysm maybe of the abdominal aorta. It seemed to have some sort of congenital.
Yeah, I'm sure there's some. I mean,
Yeah.
definitely the connective tissue diseases, can lead to abdominal aneurysms. I can't off the top of my head think of something that only causes abdominal aneurysm. And I will say, with our patient population, I think I feel like I'm always a little surprised when I have a thin person and I can feel their aorta, but that's actually normal in a thin person. Most of our patients, you shouldn't be able to because they're bigger. And it's certainly hard to feel the outline of an aorta when someone is overweight.
Thank you, Rebecca. That was really good. I have a question about, so these are large artery aneurysms, of course, but are there associations between, so if you see, people who are more likely to have thoracic, do they have more likelihood of having coronary, renal, or cerebral aneurysms?
So there's definitely genetic predispositions that can be associated with those things. And that's why when we see a thoracic aortic aneurysm, especially in the setting of an intracranial aneurysm, popliteal aneurysm, or any other vascular abnormality, then we do think about, but those are more likely to be associated with genetic abnormalities. I will say, except for popliteal aneurysms, which are just commonly associated with AAAs, as opposed to thoracic aortic aneurysms. And actually, if you see a popliteal aneurysm, you should check for a AAA because the association is strong.
So then do our guidelines support screening from head to toe?
Not that I know of. Definitely not head to toe. I would say, I think the newer guidelines are sort of general enough that they allow us to use our own clinical judgment. So yeah, but it's a good question. Bob.
So nice talk. So I'll ask you a question that a trainee asked me that I didn't know the answer to. So hopefully you know the answer. And so that's with bicuspid valve, aortic bicuspid valve. So we follow those patients obviously by echo for their bicuspid valve. But the resident said, so at age 60, they've got a bicuspid valve that's sort of stable. What's the likelihood they're going to develop aneurysmal disease later on? Or is that sort of, something we just pick up earlier and then never occurs later?
Yeah, it's a good question. I don't know the specific answer. I think that, I think that there's a cohort of patients who have the aortopathy associated with bicuspid valve, and then there's plenty who don't. And then we're always surprised sometimes by these older patients with bicuspid valve that kind of survive to being 70, 80 years old. Do we stop the screening? I mean, I think, the newer guidelines do help us, support us just with echo imaging, that we don't need to be scanning these folks and radiating them all the time. So I don't know the specific answer to your question, but I think, I think you could feel a lot more comfortable when someone's made it to, past middle age and have done okay.
So I have what I guess is a purely operational or systems kind of question, in particular with the recommendations that people who have a ascending aorta that's over 4 have some sort of additional imaging with CT, MR. And I think about my own role in the echo lab, the number of times that you see a mildly dilated aorta, I got 4, 4.1. What's your approach to, and often that's not being ordered by a cardiologist who has any idea what they need to do to follow up on that. What's your approach to communicating with people about that? Do we need to just write that clear recommendation in the report that said this is what this indicates? Do we need to, is it just a phone call? What's your view of how we handle these things?
I think that's a really good question. I think that if we made a phone call every time we saw an aorta that was 4.0 centimeters, we wouldn't have the time to read echoes. And I think that it's important to review what the guidelines are, but I do think we all know that clinically, this is something that we see, particularly in older patients. And we're going to have to figure out what to do with that. I think clinically speaking, I usually will say, even depending on indexing, I'll usually say mildly dilated, borderline dilated. I'll just try to put it there in the report. And sometimes I've, recently had a patient who had an aorta of 4.6 and it never made it to the report. It was only because my fellow was diligent in reading down a little bit. So I try to just make sure it's there. And then, what's the answer of what that primary care doctor should do with it? I'm not sure. And I think that answer depends on whether it's a 40-year-old or an 80-year-old. But yeah, it's a very good question.
It just makes me wonder whether we ought to have a standard line that says something like, guidelines recommend consideration of CT or MRI at least once. Some
Yeah.
like there's some radiology guidelines that are like that where they're there, and I think that it just, I wonder if there's a lot of things that are getting left.
But
to
as you
people
see,
that don't know what to do with the information.
that isn't necessarily recommended, right? Just that echo is recommended. And
doesn't it, is there's a class 2, right? That says.
2A, yeah.
2A, that if
Yeah.
it's greater, if
with
it's
level of
mildly
evidence
dilated.
C. So,
Right.
and I really think that's where the gradation,
Yeah.
makes a difference. If you've got an aorta that's 4.6, it's a lot different than an aorta that's 4.0. Depends also on the size of the patient. And I can't tell you how many times, the radiologists have different set of
Yeah.
of numbers, and how many times I get something back from them saying this is totally normal. And I truly disagree with them on that.
Yeah.
But
And it's compounded by the irregularity with which, as much as we all know what we're supposed to do with regard to imaging, or with regard to measurement of leading edge to leading
Yeah.
edge, but the frequency with which that happens is astoundingly low.
Yeah.
And so it seems like it's a really interesting area from a sort of system and process level.
Absolutely.
It's such a common thing to find.
absolutely. And I honestly, despite these guidelines being helpful, I don't think we know. I don't think we know the answers.
Yeah, it's a very common finding in end-stage renal disease patients who have advanced staged aortas.
Yeah.
But one thing you could put in your comments, the word aneurysm scares patients. My chart now, when they see that term intra-atrial septal aneurysm,
I take it out.
we have to, they message us, they're panicked, they worry over the weekend. We call them. That word needs to be changed in
It's
some way.
that's
It's
a
a
terrible
bad,
term.
it's a bad term.
Agree,
So,
agree.
Rebecca, could you comment on
That's what I-
follow-up? We'll see patients who have endovascular grafts that are put
Yeah.
in who may not still be seeing a vascular surgeon, and how common are leaks and what type of follow-up? for
Sure,
those
yeah,
patients?
I didn't get into all that. So definitely, with the EVARs, they need more frequent follow-up. So, once they're past that first year, they need annual, for the abdominal ultrasounds, they need annual imaging, annual ultrasounds. And then if there's any evidence of an endo leak, they need more, a CT or an MR. So unlike the surgeries where you can kind of set it and forget it after the first year and image them every 5 years, the downside of the endovascular techniques are that they need regular imaging. Well, thank you guys. Appreciate it.
The preceding program is copyrighted by Emory University.